Okay, let's get into this. Ever had that weird feeling, maybe a bit of pain, or seen a little bulge pop up around your stomach?
Yeah, or heard someone talk about a rupture.
Exactly. It's something lots of people experience
Mm.
or know someone who has. But actually understanding what's going on underneath,
Hmm?
the structure, how it works, how it can fail,
Mm.
that's really fascinating stuff.
Absolutely. It's a part of our bodies that just works, in the background until something goes wrong. And the abdominal wall, it's not just sitting there,
Right.
it's doing a lot, protecting us, letting us move.
And that's our focus for this deep dive.
Yeah.
The abdominal wall are sort of protective shield and what happens when it weakens, leading to things like hernias.
And we're grounding this conversation in a really solid source, a chapter from Bailey and Love's Short Practice of Surgery.
Which is a big deal in the surgical world, right?
Oh, absolutely. It's a standard text, so the information is detailed, it's authoritative.
So our mission today is to take that dense surgical level text and really unpack it for you. We want to go beyond just definitions. We're aiming for that deeper understanding, the why and the how. Looking at the anatomy, what causes these issues, the different types, diagnosis, treatment, complications.
Trying to get that kind of elite professional grasp, as you said, but, without needing the scalpel.
Exactly, a really comprehensive, structured understanding. So let's start with the wall itself, our protective shield.
Right. So the text describes the abdominal wall as, well, pretty complex. It's layers of muscle, you've got bone involved, and these tough connective tissues called fascia.
And it's got two main jobs that sort of pull in different directions, doesn't it?
Precisely. Job one is protection, keeping all the internal organs safe inside.
Makes sense.
But job two is movement. It has to let us bend, twist, stretch, even change the volume inside, like when we eat a big meal or during pregnancy.
And that need to be flexible to stretch and move.
Mm-hmm.
That's where the problems can start.
That's the trade-off, exactly. Flexibility means it can't be rock solid everywhere. It creates potential vulnerabilities.
Gotcha.
The textbook also defines the boundaries of the abdominal cavity, which helps understand the forces involved.
So what's holding everything in from the top?
That's the diaphragm, the big muscle separating the chest from the abdomen. And it's a really key boundary because of pressure differences.
Ah, right. Negative pressure in the chest, positive in the abdomen.
Exactly. The chest cavity sort of sucks things in while the abdomen pushes out.
And if the diaphragm is weak?
Then that positive abdominal pressure can push organs like bowel or even the stomach up into the chest. It gets drawn up because of that pressure difference. It can be quite serious.
Okay. And what about the floor? What's stopping things going downwards?
Down below, you've got the bony pelvis providing structure, and then beneath that, the muscular floor, the perineum, layers of muscle and fascia supporting everything.
And weakness there leads to prolapse, things dropping down.
Yes, exactly. Weakness in the perineum can let the rectum, bladder, or uterus and vagina in women bulge downwards. Same principle, different direction.
The text uses a cross-section view, figure 64.1, to show the layers. That seems useful.
Very useful. Looking at that transverse section, you see posteriorly at the back, it's really strong. You've got the spine, ribs, pelvis, plus big muscles like psoas, quadratus lumborum, erector spinae, super robust back there.
But even the strong back has weak spots.
It does, though hernias there are rare. The text points out two specific areas called the posterior lumbar triangles, the superior and inferior ones. They're basically small gaps in the muscle layers. Potential spots for lumbar hernias, but uncommon.
Okay, so the back's mostly solid. What about the sides and the front, where we usually think of hernias?
Laterally on the sides, you have three thinner muscle layers, the external oblique, internal oblique, and transversus abdominis. The smart thing is their fibers run in different directions, crisscrossing.
Ah, like plywood. Gives strength and flexibility.
Exactly, good analogy. Strength from the layers, but still allows movement. Then anteriorly, the front.
The six-pack muscles.
Right. The two big rectus abdominis muscles running vertically from ribs to pelvis, these muscles themselves are pretty strong.
So hernias don't usually punch right through the muscle belly itself.
No, the text is clear on that. Natural hernias don't typically happen through the main rectus muscle. The real weakness up front is actually in the midline, where those two muscles meet.
The linea alba, that central seam.
Precisely. It's a tough fibrous band made from the merging tendons of the side muscles, but it's inherently less strong than the muscles, and it's prone to stretching and developing defects. That's why you see epigastric hernias above the belly button and umbilical hernias right at it.
And there's that related condition, divarication of the recti. Figure 64.2 shows that.
Yes, and it's important to distinguish this from a true hernia. Divarication is where the linea alba stretches sideways, getting wider and thinner, so the two rectus muscles just move further apart.
So the muscles are separated, but there isn't necessarily a hole for things to poke through.
Exactly. The fascia is stretched, but there's no distinct defect letting contents protrude like in a hernia. The text mentions it's common in the upper abdomen, often in middle-aged, overweight men, and also very common after pregnancy, usually below the belly button then.
And the treatment is different because it's not a true hernia.
That's right. Medically, it doesn't usually need treatment because there isn't that risk of contents getting trapped. It's not a fascial defect in the same way, though some surgeons might offer a repair for cosmetic reasons if it's very noticeable and bothers the patient.
Okay, that gives us a good picture of the wall itself. Structure, function, weaknesses. Now let's get into what happens when things go wrong. Part 2. Abdominal hernia. Understanding the protrusion. Let's start with the basic definition.
The text defines it simply. A hernia is an abnormal protrusion of an organ or tissue through an opening in its containing layer. For abdominal hernias, it's stuff from inside the abdomen pushing out through a weak spot in the wall.
And as it pushes out, it kind of takes the wall layers with it.
Usually, yes, it pushes the peritoneum, the inner lining, and the finned outer layers of the wall ahead of it. But the text makes a good point. There are exceptions.
Oh.
Not all hernias start with a peritoneal sac. Some, like many small epigastric hernias, might begin with just extraperitoneal fat poking through the linea alba. The peritoneum only gets dragged into it later if it gets bigger.
Okay. So the sac isn't always the first thing.
Not always. The text then talks about why these happen, the anatomical causes. We mentioned the natural weak spots like the lumbar triangles, and it specifically highlights the posterior wall of the inguinal canal as another key area of natural weakness, referencing figure 64.3.
And these weak spots are often where things pass through the wall normally.
Exactly. Wherever something has to enter or exit the abdomen, it creates a potential pathway or weakness. The classic example is the inguinal canal.
Where the testes descend in males.
Right. Or the round ligament in females. That existing passageway is why indirect inguinal hernias are so common. The text even mentions that your pelvic shape, like having a wider, shorter pelvis, can slightly increase your risk.
Interesting. Pelvic structure matters.
It seems so. Other inherent weak areas mentioned are the esophageal opening in the diaphragm, the femoral canal near the groin, and the belly button scar, the umbilical cicatrix.
So those are natural spots. But sometimes it's about development going wrong. Congenital hernias.
Yes, these are hernias someone is born with because a normal developmental step didn't quite finish. The prime example is the indirect inguinal hernia.
The process is vaginalis then.
Exactly. When the testes descends, it pulls down a tube of peritoneum, the process vaginalis. Normally, that tube seals off completely. If it doesn't...
Got an open pathway.
Right. A preformed peritoneal tube leading from the abdomen down towards the scrotum or into the canal. Abdominal contents can then push into it.
And there might be hormonal factors involved in that closure failing.
The text mentions that possibility, yes. Factors like calcitonin gene-related peptide might play a role in signaling that closure, so a problem there could contribute. Other congenital hernias include diaphragm defects like Morgani and Bactylic hernias, and some umbilical hernias in newborns, which can sometimes be linked to other congenital issues.
So you can be born with a weakness, or you can acquire one through injury.
Absolutely. Injury or surgery can disrupt the wall. A surgical scar is a big one. Even with perfect healing, a scar only ever reaches about 70% of the original tissue's strength.
Which explains why incisional hernias are so common.
Very common. The text quotes rates of at least 10% after major open surgery, a laparotomy. And even the small holes from keyhole surgery, the port sites, have about a 1% risk. The hope is that more keyhole surgery might mean fewer incisional hernias overall.
And very rarely direct trauma.
Yes, like a major car crash.
Right.
Figure 64.4 shows an example. Exceptional blunt force can actually tear the abdominal muscles, creating a traumatic hernia. Rare, but possible.
So to pull all those causes together, there's summary box 64.1.
Yeah, it lists the main factors. Anatomical weakness, those built-in spots. Developmental failures like the processus vaginalis. Genetic collagen weakness, weaker tissues, basically. Trauma, sharp or blunt injuries. Aging and pregnancy, general weakening over time. And even primary nerve or muscle diseases affecting the wall.
That's a really clear summary. Okay, so how do these actually form? The pathophysiology.
Well, the text makes it clear that a healthy abdominal wall is incredibly strong. People often notice a hernia when they strain, coughing, lifting. But the strain isn't usually the cause.
It just reveals the underlying weakness.
Exactly. The strain makes an existing weak spot bulge out, makes it noticeable. The real issue is the weak structure itself, not just the pressure spike.
That's a key distinction.
And there's strong evidence for what's called the collagen disease theory for many acquired hernias. It suggests an inherited problem with the type or balance of collagen, the protein that makes up connective tissue.
So weaker building materials, essentially.
Pretty much. They've found histological differences, and there's a link between hernias and other conditions like aortic aneurysms or Ehlers-Danlos syndrome, where collagen is known to be faulty.
And smoking makes it worse.
Yes, smoking impairs collagen production and maturation, so it's a definite risk factor for developing hernias, including incisional ones, and for them coming back after repair.
Age and pregnancy contribute to just general wear and tear.
Yes, degenerative weakness comes with age and the stresses of pregnancy. And for incisional hernias specifically, besides patient factors like obesity, the text really highlights the surgeon's technique during the original closure as a major factor.
Right, how well the initial repair was done. That really emphasizes the surgeon's role. Okay, we know what they are, why they happen. Let's look inside the hernia itself and the trouble it can cause. Part 3, anatomy of a hernia and its potential trouble.
So fundamentally, a hernia needs two things: a defect, a hole in the wall, and content. Something pushing through that hole.
And the defect itself can vary.
It can. It might be through muscle and fascia, just fascia like in the linea alba, or even have bone forming part of its edge like the femoral canal. This defect, the mouth of the hernia, is usually the tightest spot, and its size varies hugely, from tiny holes to massive gaps. And the nature of that defect, how big it is, how rigid its edges are, is critical for determining the risk.
Because a small, tight hole is more dangerous in some ways.
Often, yes, especially if the edges are hard, like bone or dense scar tissue.
Yeah.
It's more likely to trap the contents.
Okay. And what actually pushes through the content?
It can start with just fatty tissue from outside the peritoneum or even bits of the bladder. But more often, especially as it gets bigger, the peritoneum itself gets pushed through first, forming a sac.
Like a balloon lining.
Exactly. And then things from inside the abdomen loops of bowel, small or large, or the omentum, that fatty apron can slide into that sac. The text also mentions sliding hernias, where structures normally behind the peritoneum, like the colon, get pushed down first and sort of drag the peritoneum with them, making up part of the sac wall.
Right. So that peritoneal sac allows things to get out. This leads to the different states a hernia can be in.
Yes. The simplest state is reducible. The contents pop out, but they can easily go back in, either on their own when you lie down or with a gentle push.
Okay.
Then you have irreducible. The contents are stuck outside. They can't go back in. This might be because of swelling or adhesions forming inside the sac, or just because the opening is too small. And irreducible hernias are inherently riskier.
Because they can get worse.
Yeah.
And the tightest point is the neck.
Exactly. The neck is that narrowest part of the sac, right where it passes through the hole in the abdominal wall. It acts like a bottleneck, a constriction ring.
And that's where the serious complications start with an irreducible hernia.
This is where it gets dangerous. When contents are trapped, that tight neck can squeeze the blood vessels supplying them. First, it usually blocks the veins trying to get blood out.
So things get congested.
Right. Blood flows in via arteries, but can't get out easily via veins. So the contents swell up, pressure rises inside the sac, and it becomes painful and tender.
And if that pressure keeps rising,
Then it can get tight enough to block the arteries supplying blood in. That's strangulation. The tissue inside the hernia becomes ischemic. It's starved of oxygen. This is usually intensely painful, and it's a surgical emergency.
because ischemia leads to tissue death.
Precisely. If blood supply isn't restored fast, the tissue infarcts, it dies. If that's bowel, it becomes gangrenous. And the text warns that infarcted, gangrenous bowel carries a high mortality risk because the dead bowel wall can perforate, leaking bacteria and toxins. The risk of this happening strangulation is highest in hernias with a small, rigid neck, like femoral hernias. The term incarcerated is sometimes used just to mean irreducible, but often implies irreducible and potentially progressing towards strangulation. The contents are in prison, essentially.
That progression is key. Reducible, then irreducible, then potentially strangulated or infarcted. Summary box 64.2 lists these states again.
Yes, it's a good recap. Occult. Hidden, not obvious clinically. Reducible. Goes back in. Irreducible. Stuck out. Incarcerated. Stuck out and potentially in trouble. Strangulated. Blood supply cut off. Ischemic. Emergency. Infarcted. Tissue has died. Very high risk.
The text also mentions some particularly tricky variations, like Richter's hernia. Figure 64.5 shows this.
Richter's is sneaky and dangerous. Only part of the bowel wall gets trapped in the hernia defect, just a little knuckle of it.
So the bowel might still be open. No complete blockage.
Exactly. Because the main channel of the bowel isn't fully blocked, the patient might not have the classic signs of obstruction. No vomiting, maybe still passing gas. They might just have localized pain.
But that little trapped bit can still die off.
Yes, that segment of bowel wall can quickly become necrotic and perforate, leading to disaster. The text specifically says femoral hernias often present this way, which contributes to diagnostic delays because the doctor might not suspect strangulation without clear obstruction.
Nasty. What about interstitial hernias?
These are hernias contained between the layers of the abdominal wall muscles. They don't necessarily push all the way through to the outside or have a full peritoneal sac. Spigelian hernias often start this way.
And internal hernias are different again?
Completely different. They don't bulge outwards at all. An internal hernia is when bowel gets trapped inside the abdominal cavity. This can happen in natural anatomical spaces or around scar tissue adhesions from previous surgery or through holes accidentally created in the mesentery during surgery.
So they present just with pain or obstruction symptoms. Okay, we've got the anatomy, types, and states. How do doctors actually figure out if someone has a hernia? Part 4. Clinical assessment, finding the hernia.
It always starts with the history, talking to the patient. Often the patient has already noticed the lump themselves. Self-diagnosis is pretty common. You need to ask about the lump, when it appears, if it goes away.
And pain. What's typical?
A simple reducible hernia is often painless, maybe just a dragging feeling. Sharp on and off pain might mean something's getting pinched at the neck. But the text stresses severe, constant pain in a hernia is a huge red flag.
Means strangulation is likely.
Highly likely. Needs urgent attention. Asking if it reduces, if they have to push it back, is vital. And asking about obstruction symptoms, nausea, vomiting, belly swelling, can't pass gas or stool, especially if it's irreducible.
The history of the hernia matters too. First time, recurrent.
Yes.
Yeah.
Is it primary, recurrent after a previous repair? Or incisional at an old scar? Recurrent and incisional ones are often harder to fix and might need different surgical plans.
And checking the patient's general health is obviously important before surgery.
Absolutely. Need to know about heart, lungs, any other conditions that might affect anesthesia risk. And medications, blood thinners, antiplatelets are crucial for surgical planning because of bleeding.
Practical things too, like can they manage day surgery?
Right. Do they have support at home? How far do they live? How mobile are they? All factors in deciding if day surgery is appropriate.
Okay, history done. Now the physical examination, how do you find it?
Key thing is examining the patient both lying down and standing up.
Why both?
Because many hernias, especially smaller ones, might disappear completely when lying flat. They only pop out when standing due to gravity and abdominal pressure.
And you ask them to cough or strain.
Yes, coughing or doing a Valsalva maneuver, bearing down, increases the pressure and can make a subtle hernia bulge out or become more obvious. The text also mentions checking for divarications specifically by having them lift their head off the pillow while lying down.
What if they swear they have a lump that comes and goes, but you can't find it right then?
The text is clear that that doesn't rule it out, especially if they were only examined lying down. You might need to re-examine them standing or straining, or consider an investigation like ultrasound.
Skin changes, redness.
Usually the skin looks normal, but if the skin over the hernia is red, hot, tender like cellulitis, that's a very bad sign. It strongly suggests the contents underneath are strangulated and possibly infected. Treat as an emergency.
The cough impulse is the classic sign, right? Feeling it bulge when they cough?
It is a classic sign, yes. In a reducible hernia, you gently press on the lump, they cough, and you feel it push outwards. But, and this is important, the absence of a cough impulse doesn't mean it's not a hernia.
Oh.
If the neck is very tight or if it's irreducible, there won't be an impulse. This is typical for femoral hernias, which often get misdiagnosed as lymph nodes, partly for this reason. And remember, other things like a saphenotharynx can also have a cough impulse.
And always check the other side,
Yeah.
especially for groin hernias.
Absolutely crucial. If you find one groin hernia, check the other side carefully. Undetected hernias on the opposite side are common, maybe up to 20% found at surgery, and the lifetime risk of getting one on the other side is high, maybe 50%.
And trying to push it back during the exam.
You can try gently. The text suggests letting the patient try first if they know how, as they're often better at it. If neither the patient nor the doctor can reduce it, then it's irreducible, and that usually means treatment is more urgent.
Two summary boxes here. Box 64.3 lists the checks.
Reducibility, cough impulse, tenderness, skin changes, checking for multiple defects or the other side, looking for old scars, checking the scrotum in men, and thinking about other possible causes.
And box 64.4 sums up the interpretation.
A swelling with a cough impulse isn't always a hernia. And a swelling without a cough impulse could still be a hernia, especially femoral. But consider other diagnoses too.
So clinical exam is usually enough, but sometimes you need more information. Part 5. Investigations when clinical exam isn't enough.
Right. The text emphasizes most hernias are diagnosed clinically. History and exam are key.
So when do you need scans?
Usually in specific situations, like the patient has symptoms, pain, intermittent swelling, but you can't find anything definite on exam.
Yeah.
Or you find a swelling, but you're just not sure what it is. Is it a hernia, a lymph node, a cyst? Or if you need to be certain the patient's symptoms, especially pain, are actually coming from the hernia and not something else nearby. Remember, simple reducible hernias aren't usually very painful. And finally, if you need more detail for planning surgery, like the exact size, the contents, are there multiple holes? Especially for complex or recurrent cases.
What about plain x-rays?
Not much use for diagnosing the hernia itself, the text says. May be helpful in an emergency if you suspect bowel obstruction.
Ultrasound.
Ultrasound is useful. Good for checking out lumps. You're unsure about hernia versus mass versus fluid versus lymph node. It's non-invasive, relatively cheap, and you can watch things happen in real time, dynamically.
But limitations.
Big limitation. It's highly operator dependent. The quality of the scan depends a lot on who's doing it. It can also be useful after surgery to check if a swelling is just fluid, seroma, or an early recurrence.
CT scans sound more powerful for complex cases.
Yes, CT is really valuable for complex ventral or incisional hernias. Shows the defects clearly, number, size, identifies the contents, can show adhesions, rules out other abdominal problems. And it's great for planning reconstruction by showing the muscle layers clearly.
MRI. More for pain.
MRI is mentioned specifically for investigating sportsman's groin or chronic groin pain where you suspect an occult hidden hernia. It's better at seeing muscle and tendon injuries, helping distinguish a small hernia from, say, an adductor strain.
And laparoscopy itself can be diagnostic.
Yes, you can use keyhole surgery just to look inside. For incisional hernias, it can help see if a laparoscopic repair is feasible. During a TAPP inguinal repair, looking inside is routine and can pick up unexpected hernias on the other side. But a limitation is that laparoscopy looks from the inside, so it might miss hernias contained entirely within the wall layers, like interstitial ones.
Summary box 64.5 pulls these together.
Yeah. X-ray limited. Ultrasound, good for uncertainty, operator dependent. CT, best for complex ventral incisional. MRI, pain sportsman's. Laparoscopy, diagnostic look but misses some.
Okay, so we know what they are, how they happen, how to find them. What do we do about them? Part 6. Management principles to repair or not to repair.
Crucial question. And the first principle the text states is, not every hernia needs surgery.
Right, that might surprise people. So why operate?
Two main reasons. The patient wants it fixed, for symptoms or appearance, or the surgeon believes there's a significant risk of complications down the line, mainly obstruction or strangulation.
And some types are riskier than others.
Definitely. Hernias with narrow, tight necks are the most dangerous. Because of this, the text is quite firm. All femoral hernias should be repaired.
All of them, even if they aren't causing problems.
Yes, because their risk of strangulation is so high. Also, any hernia that is symptomatic, causing pain or discomfort, or is irreducible, should generally be repaired unless the patient is too unwell for surgery.
What else might prompt surgery?
If it's getting harder to push back or just getting bigger over time, and for younger adults, surgery is usually offered even for mild symptoms because problems are likely to develop over their lifespan.
Summary box 64.6 cover these principles.
Key takeaways. Not all need fixing. Small hernias can be riskier than large ones if the neck is tight. Pain, tenderness, skin changes, irreducibility mean high risk. And femoral hernias always get repaired.
What about just watching it? Watchful waiting.
The text says that's a safe option for early asymptomatic inguinal hernias, especially in older folks. Studies show about 10% of those patients per year end up choosing surgery later as symptoms
A
develop.
truss, those belts.
They exist, they can hold a hernia in, but the text says they're rarely recommended now. Doesn't fix the problem, can be uncomfortable. Small, asymptomatic umbilical and epigastric hernias, often just fat, can also be watched, as the complication risk is lower.
Large incisional hernias sound like a big management challenge.
They really are. Repairing them is major surgery with significant risks, complications, recurrence. But if the neck of the hernia is very wide, the strangulation risk is actually quite low. So for obese or elderly patients with large, wide-necked incisional hernias, conservative management with a support belt is often the safer choice.
What if someone comes in acutely painful, irreducible?
That's an urgent situation. Surgery is offered. They might try Tax's first gentle, steady pressure to try and reduce it. Sometimes giving painkillers or sedation helps relax the muscles.
And if Taxis works, are they off the hook?
Not really. If it was acutely stuck, it's very likely to happen again. So the text recommends elective surgical repair soon after, even if the immediate crisis is over.
Right. So when surgery is the plan, what are the goals? Part 7. Surgical approaches, how repairs are done.
Modern hernia surgery follows a few key principles, whether open or laparoscopic. First, get the contents back where they belong.
Reduce the hernia.
Exactly. And if any tissue looks dead from strangulation, it has to be removed. If it's bowel, it needs repair or resection.
Second, deal with the sac.
Yes. Ideally, remove the peritoneal sac and close its neck. But it's not always absolutely necessary. Some laparoscopic techniques leave it. Leaving it can increase the risk of a fluid collection, a seroma afterwards, though. Open repairs often remove the sac. Laparoscopic ones usually just pull it back.
Third, close the hole, the defect itself.
That's the ideal, yes. Suture the edges of the defect back together. But it's not always possible too big. Tissues too rigid, like the femoral canal, or things like the spermatic cord need to pass through. There are complex plastic surgery techniques to borrow tissue, but they have their own downsides.
And just suturing the hole closed isn't enough usually.
For many hernias, especially in adults, suture closure alone has a high recurrence rate, which leads to the fourth principle, reinforcement.
Using mesh.
Exactly. Adding a prosthetic mesh significantly cuts down the chance of the hernia coming back. It doesn't eliminate recurrence, but it makes a huge difference. Understanding mesh is pretty essential now.
And fifth, sometimes tidying up loose skin.
Yes, especially with large hernias, removing excess skin can improve the cosmetic result.
Okay, let's really dive into mesh now, part 8. Mesh in hernia repair, the prosthetic revolution.
So mesh is basically a prosthetic material, usually a net or a sheet, used to strengthen the repair. There are a few ways it's used.
Bridging the gap.
Yes, you can lay the mesh over the defect, like a patch, fixing it to the strong tissue around the edges, tension-free. But you need a good overlap onto healthy tissue for it to hold well. Figure 64.16 shows that idea.
What about plugging the hole?
Mesh plugs were designed to just push into the defect. Seems simple, but the text says they've largely been abandoned.
Why?
Problems like meschoma, a painful lump of mesh and scar migration of the plug, or even erosion into organs like the bladder. Not good.
So augmenting is better, closing the hole, then adding mesh.
Yes, where possible. Closing the defect with sutures first, then laying mesh over that for reinforcement, tension-free, is generally seen as the best approach now. The text specifically warns against inlay mesh just sewing it edge to edge in the hole without overlap. That doesn't add much strength.
Okay, text of mesh, structure first, nets versus sheets.
Right. Net meshes are woven or knitted. They have pores, holes. The idea is your own tissue grows into these holes, integrating the mesh over time. They can be fixed with sutures, tacks, glue, or sometimes need no fixation if pressure holds them, like in the peritoneal space. Sheet meshes are solid, non-porous, or tiny holes. Tissue doesn't grow into them. It forms a capsule around them, so they need really strong fixation to stop them moving.
And the materials. Usually plastics.
Mostly synthetic polymers, yes. Common ones are polypropylene, polyester, and PTFE, polytetrafluoroethylene. Figure 64.6 shows examples. They're usually non-absorbable and designed to cause a controlled scarring reaction that reinforces the area.
Tell me about the main ones.
Polypropylene is very common. It's inert, doesn't absorb water, usually made of single filaments, resists infection well. Polyester is similar but does attract water, which some think helps blood vessels grow in. PTFE is very inert, like Teflon. It resists tissue growing in and resists things sticking to it, which is useful sometimes but limits how well it integrates.
The weight and pore size seem really important for complications.
Hugely important. Early meshes were very heavy, dense, much stronger than needed, and all meshes cause a foreign body reaction, scarring, but these heavy meshes cause a much bigger reaction.
And that excessive scarring is bad.
Yes. It leads to more collagen being laid down, which then contracts over time. This is mesh contracture. The text clarifies it's not the mesh itself shrinking, but the scar tissue around and within it contracting.
Hmm.
This can make the mesh stiff, smaller, potentially pulling away from the edges of the repair, causing recurrence. And that stiffness, the lack of flexibility, is linked to foreign body sensation and chronic pain.
So lighter, bigger pores are better now.
That's the current thinking, yes. Lightweight meshes with thinner fibers and larger pores, over 1 millimeter. They allow better tissue integration, cause less scarring and contracture, stay more flexible, and seem to lead to less chronic pain and better comfort.
What about biological meshes made from tissue?
Yes, these are derived from animal or human tissue like skin, dermis, cow heart sac, pericardium, pig intestine lining, submucosa. It's sterilized and the cells are removed, leaving just the connective tissue scaffold.
How do they work?
The idea is they provide a temporary framework. Your own body grows blood vessels and cells into it, laying down new collagen. Over time, your body's enzymes are supposed to break down and remodel the implant, replacing it with your own reinforced tissue.
Do they work as planned? Limitations.
It's variable. How fast they break down depends on the material, and the environment infection makes them degrade really quickly. Some are treated to resist breakdown, but that might also hinder remodeling. They're also very expensive, and the text says their exact role isn't fully sorted out yet.
And absorbable synthetic meshes.
They exist, made from polymers that dissolve over time, used mainly for temporary abdominal closures or short-term support. But the text says they're generally not good for permanent hernia repair because they disappear too fast, before enough strong scar tissue forms. Newer, slowly absorbable synthetics are being developed, but long-term results aren't known.
Then there are special meshes for putting inside the abdomen, tissue-separating ones.
Yes, this is crucial for laparoscopic repairs where mesh often ends up touching the bowel. Standard meshes would cause massive adhesions if put directly on bowel, so these special meshes have two sides.
One's sticky, one's slippery.
Basically, yes. One side is designed to stick to the abdominal wall and allow tissue ingrowth. The other side, facing the bowel, has an anti-adhesive coating, like cellulose, collagen, or PTFE, to stop things sticking. Figure 64.7 shows adhesions forming even with these.
But they're not perfect.
No, the text says none are 100% effective. And putting mesh inside the peritoneum, intraperitoneal, still carries risks adhesions causing bowel obstruction, or rare but serious erosion of the mesh into the bowel. So surgeons try to avoid intraperitoneal placement if possible.
Summary box 64.7 is good for remembering mesh features.
Net versus sheet, synthetic versus biological, pore size, big pore, less fibrosis pain, non-adhesive surface, absorbable versus non-absorbable, key characteristics.
And where you put the mesh is just as vital. Figure 64.8 shows the layers.
Absolutely. The strength comes from integration or fixation. Mesh needs to be flat, tension-free, on healthy tissue with good overlap. The text describes the main positions or planes.
Onlay is most superficial.
Yes, onlay is placed just under the skin, on top of the muscle fascia. Risks include exposure if the wound opens and potential skin problems or fluid collections from raising the skin flaps.
Inlay is not recommended.
Correct. Edge to edge in the defect, not good.
So deeper is generally better. Sublay or extraperitoneal.
Generally preferred, yes. Sublay is just deep to the muscle fascia. Extraperitoneal is in the space between the peritoneum and the muscles. These positions have a mechanical advantage. Abdominal pressure pushes the mesh against the wall, helping hold it. This is often the gold standard.
And intraperitoneal is least favored.
Yes, because of the adhesion and erosion risks. These planes apply to both open and keyhole techniques.
What are the main limitations to using mesh overall?
Infection is the big one. Infected synthetic mesh is a disaster, usually needs removing. Salvage is sometimes possible but difficult. Cost is another factor, especially for the newer or biological types. And the text wisely notes that price and novelty don't automatically mean better or safer. A simple, large pore synthetic mesh is often the workhorse.
That's a fantastic overview of mesh. Okay, let's apply this to specific hernia types now. Part 9. Specific hernia types A guided tour, starting with the most common. Inguinal hernia. Figure 64.9 shows the locations.
Inguinal hernia is the rupture people talk about. By far the most common, especially in men, about 10 times more often than women. Two main types: indirect, lateral oblique, and direct medial.
Different causes and paths, but treated similarly now.
Fundamentally different origins: indirect, usually congenital; direct, always acquired weakness. Different paths through the groin, but they're close together anatomically, and modern mesh repairs often cover both potential areas anyway. Summary box 64.8 hits the main points.
To get it, we need the inguinal canal anatomy, figure 64.10.
It's basically a tunnel about 4 centimeters long, slanting through the lower abdominal wall layers. Starts inside at the deep inguinal ring, a hole in the transversalis fascia, midway between the hip bone point ACIS and the pubic tubercle. That's where the spermatic cord, or round ligament, enters the canal from the abdomen. Just medial to this ring are the inferior epigastric blood vessels.
The muscles form the roof.
Yes, the internal oblique and transversus muscles arch over the top, forming the conjoint tendon medially. But below that arch, the back wall is weaker, mainly just fascia. The canal runs down and medially, ending at the superficial inguinal ring, a V-shaped slit in the external oblique tendon just above the pubic bone, where the cord exits.
So walls and floor.
Anterior wall is the external oblique tendon. Posterior wall is the transversalis fascia, backed by conjoint tendon medially. Roof is the arching muscles conjoint tendon. Floor is the inguinal ligament, the rolled under edge of the external oblique.
Contents differ in males and females.
Right. Males, spermatic cord, artery, veins, lymphatics, vas deferens, nerve, covered by cremasteric muscle. Females, round ligament and a nerve. Nerves like the ilioinguinal also run nearby.
Okay, anatomy clear. So an indirect inguinal hernia.
Follows the path of the spermatic cord, pushes through the deep inguinal ring. Inside that persistent processus vaginalis, we talked about the peritoneal tube that didn't close.
So congenital in origin, even if it appears later in life.
Yes. In babies' kids, it's always this type. In adults, the pre-existing tube is there, and the hernia develops as the muscles around the deep ring weaken over time. Because it follows the cord, it can go all the way down into the scrotum.
Becoming a scrotal hernia. Got it. And lateral, or oblique, refers to its path.
Yes. Starts lateral to the epigastric vessels, runs obliquely through the wall. Direct hernias can't reach the scrotum.
So how is a direct inguinal hernia different?
Always acquired, not following the cord. It's a direct bulge through a weakened area of the posterior wall, medial to the epigastric vessels.
Hasselbalch's triangle, figure 64.11.
Exactly. That triangle bordered by epigastrics laterally, rectus muscle medially, inguinal ligament below is naturally weaker, especially if the transversalis fascia thins out. Direct hernias push straight through there. More common in older people, usually have a wider opening, so less likely to strangulate. And the bladder can sometimes get pulled into a direct hernia, figure 64.2.
What's a sliding inguinal hernia?
A type of acquired indirect hernia, but instead of peritoneum pushing out first, retroperitoneal fat, or an organ like the colon, left side, or cecum, right side, slides down first, dragging the peritoneum with it. So the bowel wall itself forms part of the hernia sac wall. Surgeon needs to be careful not to cut the bowel during repair.
And pantaloon. Sounds colorful.
Just means you have both an indirect and a direct hernia on the same side. Looks like a pair of trousers hanging over the epigastric vessels.
There's a classification system.
European Hernia Society system. P for primary, R for recurrent, L for lateral, indirect, M for medial direct, F for femoral, then size, 1 at 1.5 centimeters, 2, 1.53 centimeters, 3 centimeters. So PL2 equals primary lateral size 2, simple code.
Diagnosis is usually clinical. Figure 64.13 shows the bulge.
Usually. Groin lump, appears standing coughing, goes away lying down. Trying to distinguish direct versus indirect by pressing on the deep ring is tricky and often doesn't change management much with mesh repairs anyway.
What if you can't find it on exam, but the story fits?
Don't dismiss it, re-examine standing straining, or get an ultrasound.
An irreducible, tense hernia needs more thoughts.
Yes. No cough impulse, maybe? Need to consider other groin lumps. Lymph node abscess lipoma may need ultrasound or CT.
And big scrotal hernias versus hydrocele.
Keys. Can you get above the swelling? Hernia extends up into the canal. Hydrocele is contained within the scrotum. Ultrasound confirms if unsure. And need to avoid misdiagnosing femoral or spigelian hernias as inguinal or a Safina varix.
So essential checks. Scrotum, other side.
Yes. Always check the scrotum for other issues, and always check the contralateral groin. Occult hernias are very common there. Offering bilateral repair isn't standard yet, despite the risk.
Investigation's usually not needed for typical cases.
Mostly clinical diagnosis. Scans might miss it if it reduces when lying down. Laparoscopy can see defects inside, but not interstitial ones.
Okay, management. Lots of operations listed in summary box 64.9.
Options range from doing nothing to emergency surgery. Watchful waiting is safe for early, asymptomatic direct hernias, especially in the elderly. Trusses aren't really recommended. Elective surgery is for symptomatic, irreducible, or younger patients. Can be done under local, regional, or general anesthetic.
Herniotomy just for kids.
Yes. Just removing the sac is enough for kids' congenital hernias. In adults, recurrence is high without strengthening the floor. Herniorrhaphy.
Open suture repairs Bassini Schultes.
Bassini, 1890s, was the classic. Open canal, deal with sac, suture conjoint tendon down to inguinal ligament to reinforce the floor. Figure 64.44. Schultes is a modification, more layers, technically demanding low recurrence in expert hands, but maybe not much better than Bassini otherwise.
Maloney Darn.
Desarda. Maloney darn uses a continuous suture woven back and forth like darning a sock. Good results, used where mesh is costly. Desarda uses a strip of the patient's own external oblique tendon to reinforce. Also good results, similar to Schultes.
But open flat mesh, Liechtenstein took over, figure 64.15.
Yes, in the 80s. Tension-free repair. Open canal, deal with sac, then lay a flat mesh, polypropylene usually, over the posterior wall, slit for the cord, sutured lightly in place.
Advantages were lower recurrence, faster recovery.
Lower recurrence confirmed, especially early on, but the big issue that emerged later is chronic pain, up to 20%. That's its main downside compared to laparoscopic now. Still very common, though.
Plugs aren't recommended anymore.
No. Too many complications like myxoma, migration, erosion. EHS guidelines advise against them.
Open preperitoneal, Stoppa.
Placing mesh deep behind the muscles. Stoppa used a big mesh for bilateral recurrent. Good technique, but largely replaced by laparoscopic TEP-P, which does the same thing minimally invasively.
Which brings us to laparoscopic repair, TIP-P and TKPP.
The main minimally invasive options. Goal is the same. From the inside, reduce the hernia, place a large mesh, 10 by 15 centimeters plus in the preperitoneal space, covering all weak spots, direct, indirect femoral areas. Figure 64.16 shows the view.
TIP-P stays outside the main abdominal cavity. PPP goes in first.
Correct. TAPP works entirely in the space between peritoneum and muscles. TAPP enters the peritoneum, then cuts the peritoneum to get into that preperitoneal space, then closes the peritoneum over the mesh.
Advantages of lap repair.
Less pain, acute and chronic, up to 5 years versus Liechtenstein, quicker return to activity, fewer wound issues, infection, hematoma. Especially good for bilateral hernias or recurrences after open surgery. Needs more training, though.
Robots.
Used increasingly. No major proven patient benefit yet over standard lap. Better view, ergonomics for the surgeon. Cost is the big hurdle for simple hernias.
So tailor the approach.
Absolutely. No single best op for everyone. Depends on surgeon, patient, hernia type. Discuss options, including no operation. Summary box 64.9 lists them all.
Emergency surgery for strangulation.
About 5% present acutely. Time critical if bowel ischemic. Principles same as elective. Open or lap possible. Bowel resection needed and about 20% increases risk. Might need bigger incision. Mesh usually okay unless frank contamination with antibiotics.
Complications of surgery. Summary box 64.1 UR.
Common procedure, but things can happen. Immediate. Bleeding hematoma, urinary retention, temporary nerve block from local anesthetic.
Medium term. First week.
Pain, bruising, swelling, very common, less common. Seroma, fluid collection, especially if sac left. Wound infection. Routine antibiotics, not usually recommended for elective mesh repairs now.
Long term. Recurrence and chronic pain are the big worries.
Yes. No op is recurrence-free. Aim for 5% at 5 years. Mesh better than suture. No big difference between mesh types or open versus lap mesh. Big factor. Specialist hernia surgeons get lower rates of both recurrence and chronic pain.
Chronic pain is a major issue, up to 20%. Less with lap.
Yes. Affects many. Less common severe after lap versus Liechtenstein can be nerve pain, neuralgic, from injury or irritation by suture mesh. Risk factors. Female, young, pre-op pain, other pain syndromes. Careful nerve handling is key. Identify, protect, avoid staples near them in lap. If nerve cut, do it high, very end.
Rare things like testicular damage.
Very rare testicular artery damage, infarction. Serious in young men, but no evidence hernia surgery affects fertility.
Sportsman's groin, different from a standard hernia.
Yes. Severe groin pain radiates. Common in contact sports. Tender near canal, pubic bone, adductors. Pain on resisted hip movement. Usually NO, actual hernia found.
Mostly muscle tendon strain.
Usually adductor strain or pubic joint issues. Can be muscle tears, Gilmore, or just stretched posterior wall. Need to rule out hip, spine, and bladder problems.
Investigation. MRI.
MRI best for muscle ligament issues. Ultrasound laparoscopy to exclude a hidden hernia.
Surgery for it.
Last resort. High failure rate for pain relief. Even if a small issue is found, the pain might be coming from something else.
Okay, moving from the groin to the front. Ventral hernias. Includes lumbar too. Primary versus incisional. Peristomal included. Summary box 64.13.
Primary ventral. Umbilical, epigastric, spigillian, lumbar, traumatic. secondary, incisional, peristonal.
Let's start with umbilical hernia, from the belly button defect.
Right. Defect present at birth usually closes, can be delayed or reopen stretch in adults.
Common in babies, often goes away.
Very common, up to 10% infants, more in preemies, much more in black infants. Usually appears after birth, bulge increases on crying, but rarely causes problems, strangulation under age 3.
So watch and wait for kids under 2.
Yes, if symptomless. 95% resolve. Reassure parents. Surgery only if persists past age 2 or symptomatic large. Simple closure of the fascial defect is usually enough. Summary box 64.14 reinforces this for kids.
Adult umbilical hernias are different.
Usually due to stretching reopening factors. Pregnancy, obesity, liver disease sites can be right at umbilicus or just above perumbilical, often grouped together now.
Content and risk in adults.
Small ones often just fetamentum. Larger can have bowel. Risk of getting stuck, irreducible, obstructed, strangulated is higher in adults than kids due to narrower neck relative to sac size.
Clinical picture figure 64.18.
Common in overweight men, postpartum women. Bulge often slightly to one side, crescent shape. More women affected. Often painful, tension pinching. Skin can thin out over large ones.
Treatment for adults. Surgery usually advised.
Yes, especially if contains bowel due to strangulation risk. Small fatty ones might be watched, but often enlarge. Open or lap repair possible.
Open repair options. Mayo.
Very small defects, 1 centimeter, maybe simple suture. Slightly larger, maybe a darn suture. Up to 2 centimeters, classic Mayo repair. Transverse incision, deal with sac, overlap fascial edges like a waistcoat, suture. Popular, but tension increases with size.
But mesh is generally better now, even for smaller ones. Figure 64.19 shows a huge one.
Yes, current evidence strongly favors mesh for defects 2 centimeters. Many use it down to 1 centimeter. Significantly lower recurrence than suture alone in adults.
What about pregnancy or liver disease impact?
Hernias appearing during pregnancy. Watch may improve postpartum with exercise weight loss. Avoid surgery during pregnancy. Liver cirrhosis, child's BC with ascites. Surgery is extremely risky. Needs careful selection, specialist input. If done, maybe find suture repair to avoid ascites leak. Mesh is risky with ascites.
Laparoscopic repair for umbilical.
Common, especially 2 centimeters or obese. Ports lateral. Reduce contents from inside. May need to take down falciform ligament. Place anti-adhesion mesh, intraperitoneally fix it. Figure 64.20 view.
Pros and cons of lap umbilical.
Pros, fewer wound issues, good for large mesh, good for obesity, multiple defects. Cons, needs special gear, expensive mesh, risk of intraperitoneal mesh issues, adhesion erosion rare. Post-op pain can be bad initially, tack pain.
Emergency repair is common for umbilical.
Yes, narrow neck means high risk of incarceration strangulation. Delay gangrene. Large ones can have strangulation in just one part. Usual repair at open in emergency. Avoid mesh if strangulated, infected. Deal with tissue, suture repair, maybe definitive mesh later.
Epigastric hernias. Midline above umbilicus.
Yes, through linea alba. Defects start small, transverse elliptical, 1 centimeter often.
Content often just fat. Figure 64.21.
Mostly, yes. Fat pokes through, spreads under skin, mushroom shape. Rarely gets big enough for sac bowel. Can be multiple defects along the midline. Missing one is cause of recurrence.
Who gets them? Symptoms.
Fit men, but also older overweight people. Can be painful even when small fat gets pinched. Tender locally, often irreducible. Can look like a lipoma. Cough impulse variable.
Do they all need surgery?
Not necessarily. Tiny fatty ones might resolve. Small moderate ones without bowel aren't dangerous. Surgery mainly if symptomatic pain or if they contain bowel. Always repair them.
Surgery? Open or lab?
Both possible. Open. Incision over lump. Find defect, push fat back or remove it, close small defect with sutures. Larger sac, like umbilical repair, often mesh. Lap, similar to umbilical, may need to take down falciform. Reduce fat fully.
Spigelian hernias. Uncommon. Side of the rectus muscle.
Yes, through spigelian fascia, transversus aponeurosis. Contract between muscle layers, usually below umbilicus level, near rectus edge. Almost always above arcuate line. Figure 64.22 example.
Content. Symptoms.
Young, often just fat. Older, often sac, bowel possible.
Yep.
Young, intermittent pain, pinched fat. Lumped may not be palpable. Older, reducible swelling, maybe obstruction symptoms.
Diagnosis tricky. Need imaging.
Can be. Suspect based on location symptoms. CT confirms best. Ultrasound useful, especially standing.
Treatment. Surgery recommended.
Yes, narrow neck, high strangulation risk. Open or lap? Open. Incision over area, open external oblique, deal with sac intense, repair defect. Suture or mesh, often placed deep to external oblique. Lap, useful if diagnosis unclear. If just fat, might need extraperitoneal exploration. If sac, IPOM, or TAPP repair, TAPP more common now to avoid IP mesh. Summary box 64.15, rare, misdiagnosed, high complication risk.
Lumbar hernias, back flank area.
Primary ones rare, usually through inferior triangle of petite, iliac crest, external oblique, latissimus. Figure 64.23, less often superior triangle, 12th rib, sacrospinalis, internal oblique. Figure 64.24a, often mimicked by incisional hernias from kidney surgery.
Differential.
Lipoma, incisional hernia, cold abscess, pseudohernia, muscle paralysis from nerve damage. Tend to enlarge. Surgery recommended. Open or lap. Mesh usually needed, defects hard to close. Lep TAPP popular for smaller ones. Patient side lying. Mesh placed extraperitoneally. Large lumbar incisional hernias very difficult, especially with nerve damage bulging.
Traumatic hernias from direct injury, not weak spots.
Right. 3 types at stab wounds. Muscle tears from blunt trauma, figure 64.4, or bulging from muscle atrophy after nerve damage.
Features and treatment.
Present like other hernias. Key is trauma history, non-anatomical location. CT useful to see damage. Surgery if symptomatic or risk of trapping. Stab wound straightforward. Diffuse bulges, hard plicket stretched layers. Reinforced with mesh, some bulge may persist.
Incisional hernias. Huge topic at old scars.
Defect in muscle fascia at scar anywhere after laparotomy. Incidence 10-50% after open, 1-5% port sites. Many factors: patient, collagen, obesity, healing issues, wound, infection, tension, surgeon, suture choice, technique.
How do they form?
Fascial disruption early post-op. Can be obvious dehiscence, wound opens, or subtle failure. Bulge appears later as defect enlarges.
Prevention is key.
Optimize patient, smoking, weight, nutrition. Good closure technique. Smaller, closer bites, 5 millimeters apart, 5-8 millimeters back. Fascia only, minimal tension. 20 slow resorbable suture. Suture.wound length ratio 4.1. Drains separate. Prophylactic mesh in high-risk patients, obesity or peristomal, can cut rates 50%.
Clinical features. Summary box 64.16. Figure 64.2526.
Local bulge and scar or diffuse bulging can be multiple defects, get bigger. Skin things can ulcerate. Obstruction common, adhesions often coexist. Strangulation less common if wide neck, but most likely if small fibrous defect, large sac.
Management.
Asymptomatic, maybe no treatment. Binder for support symptoms. Balance risks benefits of surgery based on patient health. Complex ones need specialist referral. Optimization prehab critical for elective repair, weight loss, smoking stop, fitness.
Principles of repair.
1. Cover whole incision length. 2. Approximate fascia if possible, minimal tension. 3. Use mesh, reduces recurrence.
When not to use mesh.
Gross contamination, perforated bowel. Maybe okay in clean contaminated elective bowel resection with tearing antibiotics. Use mesh to augment closure, not just bridge gaps. Causes pseudo-recurrence bulge. Small ones can be bridged if mesh defect ratio large.
Mesh position open.
Onlay simplest, risks exposure, skin issues. Inlay bad. Intraperitoneal difficult open, risks adhesions. Retromuscular behind rectus often preferred.
Laparoscopic repair.
Common now. Look inside, divide adhesions, exposed defect. Some close defect first, some just bridge. Risk bulge. If large defect, figure 64.27 CT. Mesh placed interperitoneally IPM. Needs special anti-adhesion mesh.
Risks of lap incisional.
Bowel injury during an adhesion dissection can be missed, lead to peritonitis.
Peristomal hernias.
Yeah.
Round stomas.
Creating stoma is creating a hernia defect. Enlarges over time, 50% rate. Huge problem for patients. Bag fit, leaks, obstruction. Best is reverse stoma, if possible. Resiting stoma doesn't work well. Repair has high failure. Mesh lowers recurrence but risks erosion infection near stoma. Best mesh position, retromuscular. Lap repair uses modified Sugarbaker or keyhole mesh, prevention. Prophylactic mesh at stoma creation, promising results.
Rare external hernias next. Perineal.
Very rare primary. Mostly incisional after pelvic surgery trauma. Bulge through pelvic floor, types post-op rectal prolapse into labia women, into ischiorectal fossa. Repair complex, combined abdomen perineum approach, often needs mesh flap.
Obturator hernia through obturator canal in pelvis.
Rare. 6x more in women, 60 years, often thin. Swelling hidden by muscle, maybe pain down inner thigh. Push-up romber. Leg often held flexed, sometimes felt on internal exam, vaginal rectal.
Often diagnosed late strangulated.
Yes, subtle signs. Often found on CT for pain obstruction, frequently Richter-type strangulation, sometimes seen incidentally at laparoscopy.
Surgery needed.
Always. Often urgent, usually found at laparotomy. Constriction at fascia. Reduced contents. Defect closure hard. Bone nerve vessels. Best. Mesh placed extraperitoneally. Or use broad ligament flap. Lap-T APP repair possible with mesh. Hard to reduce laparoscopically if stuck.
Gluteal and sciatic hernias. Buttock area.
Extremely rare. Through sciatic foramina, differential. Lipoma, abscess, aneurysm. CT helps. Repair difficult. Bone ligaments, mesh useful, but must avoid placing on nerve vessels.
Okay, moving beyond hernias, part 10. Conditions of the umbilicus, beyond hernia and abdominal wall infection.
Umbilical issues in adults, besides hernias, chronic infection common, hygiene, trapped debris, can cause cellulitis, needs treating before surgery, chronic sinus after repair, usually infected mesh suture needs removal.
Fetal remnants.
Vital intestinal duct, if persists at umbilicus, feculent discharge, bowel and Meckel's, endometriosis, cyclical bleeding, erectus bladder connection. If patent urine discharge, often triggered by bladder pressure issues, needs excision if persists after treating bladder problem.
Tumor at umbilicus, Sister Joseph's nodule. Figure 64.28.
Usually secondary spread from internal cancer, stomach, colon, ovary, via ligaments. Bad sign indicates advanced disease. Primary cancer, squamous, urothelial, very rare, needs excision.
General abdominal wall infections.
Skin infections common, cellulitis, abscess, need antibiotics, maybe drainage, more serious if deep bacteria involved, surgery, perforation.
Synergistic gangrene. Figure 64.29.
Rare, nasty mix of bacteria, rapid tissue death, systemic illness, needs immediate antibiotics, aggressive surgical debridement, high mortality.
Necrotizing fasciitis. Fourniers.
Severe, rapid spread through subcutaneous layers fascia. Abdomen, chest, thighs, perineum, septic shock, gas crepitus, foul smell, high risk if diabetic debilitated but can hit healthy people. Utter emergency, aggressive repeated surgical debridement within hours is key. High mortality, survivors need skin grafts, needs distinguishing from simple cellulitis lymphatic edema.
Cutaneous fistula, opening to the skin.
Rare spontaneously, usually from chronic deep abscess, bowel perforation, appendicitis, diverticulitis, cholecystitis, eroding out. CT finds source, treat source, drain abscess, remove organ. Malignancy can erode out. Crohn's disease prone to fistulate.
Final section, part 11. Other significant abdominal wall issues. Abdominal compartment syndrome.
Dangerously high pressure inside the abdomen, caused by severe sepsis, pancreatitis, or bleeding, ruptured aneurysm. Fluid swelling increases volume.
Abdominal wall can only stretch so far.
Exactly. Pressure rises,
Wow.
20 minimal HE measured via bladder, cuts off blood flow to organs, multi-organ failure, kidneys, heart, lungs.
Management. Leave abdomen open sometimes.
Yes. If pressure too high, needs surgical decompression, or after massive surgery, if too swollen to close safely, laparoscopy or open abdomen, cover contents temporarily, mesh, dressings, VAC therapy, plan for delayed closure, maybe multiple trips to OR.
Abdominal wall neoplasms. Tumors.
Rare. From muscle, fascia, bone, benign or malignant. Desmoid tumor mentioned specifically. Fibrous tumor, linked maybe to trauma, FAP, needs wide surgical excision due to high local recurrence risk.
That was incredibly comprehensive. We've gone from the basic wall structure, the weak spots, all the way through hernia types, causes, diagnosis, the complexities of management, and mesh.
Right, down to the specific details of inguinal versus umbilical versus femoral repairs, open versus lap, the challenges of incisional and peristomal hernias, and even rare types and other wall conditions like infections and compartment syndrome.
Drawing on that surgical textbook level of detail really gives that elite professional perspective on these very common problems, understanding the anatomy, the biomechanics, the material science of mesh. It all fits together.
And hopefully this deep dive helps you appreciate the nuances. Why one hernia might be watched while another needs urgent surgery. Why mesh is revolutionary but also has downsides like chronic pain. It highlights the body's design, its vulnerabilities, and the sophistication of surgical solutions.
So, a final thought to leave you with. We've seen how hernias are often fixed mechanically, reinforcing a structural weakness. But chronic pain persists as a major issue, despite mesh and advanced techniques. What does this tell us? Perhaps that fixing the plumbing isn't always enough. How much do we still need to learn about individual biology, inflammation, nerve responses, and even psychological factors to truly overcome this common complication of hernia repair?